Okay friends, now we are starting with another topic, that is antibiotics in pediatric dentistry. Introduction, indications, contraindications, recommendations, conclusion and references. So introduction, as we know that the most commonly prescribed drugs in pediatrics are the antibiotics. So due to this overuse, the development of antimicrobial oral resistance has been seen in patients who are less than 3 years, as mentioned by the study in Reddy et al. 2003. In their study on the antibiotic resistance in pediatric patients, they concluded that it was seen that there was oral microbial resistance for a patient who was less than 3 years, so by Reddy et al. So therefore this calls for the awareness and guidelines for the proper indication and contraindication where to use antibiotics and where to not. So let us start with the indications. In cases with oral wounds, intraoral puncture wounds where contamination with extrinsic bacteria, debris, foreign bodies, open fracture, etc. So this increases the risk of infection, so should be managed with systemic antibiotics. Tetanus immunization status must be determined. A booster dose, if it is not there, a booster dose, tetanus immunization status is not determined, then booster dose within 48 hours should be prescribed to the patient. In cases with irreversible pulpitis, necrotic pulp or localized acute apical abscess, no antibiotic should be prescribed if no systemic signs and symptoms are present. As there is lack of blood circulation in the root canal in such cases, so there will be no use of giving antibiotic, as it won't show any action. In cases with soft tissue swelling or endodontic origin, apical abscess or alveolar abscess, acute odontogenic infection or abscess where there is diffuse swelling and there is pyrexia, that is increase in the body temperature is there, within the last 24 hours, it indicates for systemic response. Antibiotics should be prescribed in such cases. You understood? In cases of localized infection, pulpal necrosis, necrotic pulp, we are not giving antibiotics, but when a systemic condition is involved, then antibiotic prescription is given. Next is the acute facial swelling with dental origin or facial cellulitis. Now in cases of facial cellulitis, signs and symptoms of systemic involvement is there. It can be septicemia, that is fever, malaise, asymmetry, facial swelling, trismus, etc. So according to the guidelines, the drug of choice is amoxicillin, 2 to 3 days, maximum for 5 days. For children who are less than 40 kgs, 20 to 40 mg per kg per day in every 8 hours. For children who are more than 40 kgs, 250 to 500 milligram every 8 hours. For the patients who are penicillin allergic, metronidazole 3 days for children, 30 mg per kg per day in every 6 hours, or azithromycin for 3 days, 5 to 12 mg per kg per day, or clarithromycin for 7 days, 7.5 mg per day in every 12 hours is given. Okay, now next is dental trauma. As we have already studied in the dental trauma chapter, that systemic antibiotics are recommended in dental trauma cases, and tetracycline is the choice of drug for 7 days twice a day. For the patients who are less than 12 years, tetracycline may cause discoloration, so in such cases we prescribe penicillin. And for luxation injuries in primary teeth, no antibiotics are indicated. Okay, next is the pediatric periodontal disease. No antibiotics is recommended for dental plaque or eruption gingivitis or gingivitis due to mouth breathing. No antibiotics. Next is patients with aggressive periodontitis. Amoxicillin 50 mg per kg per day is given, and metronidazole 30 mg per kg per day for every 8 hours. Patient who are penicillin allergic patients, azithromycin for 3 days and metronidazole for 10 mg per kg. Okay. Next is in cases of patients who have gingival disease due to systemic origin, like the papillon leaf fever syndrome, etc., antibiotic therapy is needed. Next is the viral conditions. Acute primary herpetic gingivostomatitis, no antibiotic therapy is needed until there is a secondary infection exists. Next is the salivary gland infection. Antibiotic therapy is required, and if there is no improvement within 24 hours of antibiotic therapy, an incision and drainage along with antibiotic therapy is given. Amoxicillin plus clavulanate is the empirical choice, and clindamycin for penicillin allergic patients. Okay, now coming on to the I have made a flow chart means a table so that you can understand where it is indicated. So conditions like acute apical abscess with systemic involvement, signs and symptoms: localized fluctuant swelling, temperature more than 38 degree, malaise, lymphadenopathy, trismus, yes, antibiotics are indicated. Cellulitis or osteomyelitis, severe infection, spreading of infections, osteomyelitis, yes, antibiotics indicated. For acute necrotizing ulcerative gingivitis, strong continuous pain, fetid odor, generalized systemic manifestation plus low grade fever, lymphadenopathy plus malaise, yes. Aggressive periodontitis, rapid loss of connective tissue attachment and bone loss, yes, antibiotics indicated. Now next, coming on to the recommendations by various authors. According to Palmer et al. 2006, acute odontogenic abscess which is associated with systemic conditions, we will give amoxicillin 2 to 3 days, maximum 5 days. For penicillin allergic patients, metronidazole for 3 days, erythromycin or azithromycin for 2 to 3 days. Next, by Stephen et al. In 2017, odontogenic infections, for first 3 days we'll give penicillin V or amoxicillin, clindamycin and cephalexin. Okay, patients with penicillin allergy, all the C: clindamycin, clarithromycin and cephalexin. For late, that is more than 3 days, we'll give clindamycin, penicillin V, metronidazole or amoxicillin metronidazole. For penicillin allergic patient, clindamycin is given. Now coming on to the AAPD guidelines, acute facial swelling of dental origin, empirical choice is the penicillin or penicillin plus metronidazole if anaerobic conditions are involved, or we can give cephalosporins, alternative choice for odontogenic infections. Then Dar et al. In the year 2018 for cellulitis, he told amoxicillin for 2 to 3 days or maximum 5 days, and for penicillin allergic patient, metronidazole for 3 days or azithromycin or clarithromycin for 7 days. AAPD guidelines on localized aggressive periodontitis or ANA, tetracycline or tetracycline with metronidazole or metronidazole plus amoxicillin. If patient is febrile, then metronidazole plus penicillin. According to Radhika Muppa et al. 2016, in cases of localized aggressive periodontitis, amoxicillin plus metrogel for 15 days. Okay, I hope this recommendations were clear. Again, I'll tell. Palmer et al. 2006, for acute odontogenic abscess with systemic condition, amoxicillin. For penicillin allergic patient, metronidazole, erythromycin, azithromycin. For Stephen et al. 2017, odontogenic infections, penicillin first 3 days, penicillin or amoxicillin, clindamycin, cephalexin. Allergic patients, clindamycin, cephalexin, clarithromycin. Late 3 days, clindamycin, penicillin V, metronidazole or amoxicillin metronidazole. For penicillin allergic patients, clindamycin. AAPD guidelines, acute facial swelling of dental origin, empirical choice penicillin or penicillin plus metronidazole or cephalosporins. Dar et al. In 2018, cellulitis, amoxicillin maximum for 5 days, penicillin allergic patient, metronidazole, azithromycin, clarithromycin. AAPD guidelines, localized aggressive periodontitis or ANAC, tetracycline or tetracycline plus metronidazole or metronidazole plus amoxicillin. If patient is febrile, metronidazole plus penicillin. According to Radhika Muppa et al., localized aggressive periodontitis, amoxicillin plus metrogel for 15 days. So to conclude, a conservative use of antibiotics should be used. Okay, a proper dosing regimens should be followed, and means conservative use means where it is indicated there only we should give, or else it might cause the antibiotics resistance. Should not prescribe broad spectrum antibiotics where treatment can be done using the narrow spectrum antibiotics. Prescribing once or twice daily rather than thrice daily antibiotics. Prescribing analgesics to supplement operative treatment for pain rather than antibiotics. Follow-up is the must to evaluate the response or to check if any adverse effect have happened. References taken from Dhirija et al. 2020, Journal of Family Medicine and Primary Care, and AAPD reference manual on the use of antibiotics, medications for oral condition 2022. I hope it was clear and it was informative. If you have any doubt, please post it in the comment section. I'll be happy to help. Thank you.